talk is on healthy veins and healthy legs. And I figured I would start off with this slide about who I am, what I do, and why. And it's kind of an interesting thing, not in that who I am, but just in what I do and why. And I feel like I like to tell people that I went into vein health because it's definitely one of those fields in medicine that first, not even a lot of people have heard of. And then second, we just don't have a lot of vein doctors in the state of Maine. In fact, I'm the only fellow of phlebology, and I think right now we only have 3 other board-certified phlebologists or vein doctors in the state. So I was very fortunate to be able to open my own practice here in Maine 8 years ago. And with that, when I opened, I had 3 main goals I wanted to fulfill. The first one was I wanted to be able to help people with vein problems and provide the highest level of care I could. So to make it a real, true patient-centric practice, which is becoming less and less common these days in the world of medicine the way it is. And then the 2 other components had everything to do with education, so more or less why I'm here tonight, as well as I wanted to make contributions to the field of phlebology, which you can't always do in certain environments. So phlebology being a very young field, I tried to set myself up to be able to either contribute research or time or something to the greater field of vein health. And education, not just of my community, but also my fellow physicians in the state of Maine. A lot of docs in Maine have a hard enough time keeping up on all the current things in their day-to-day practice, let alone what vein care is or what the latest and greatest in vein care are. So I started making a lot of print material, including a magazine that Jen Boggs is very instrumental on helping with. And we try to print these out as frequently as we can, but as a labor of love, try not to hold ourselves to critical deadlines. But we have a lot of print material, so please help yourselves to any of the information up here on the desk afterwards. And through these magazines, ideally, I can help keep other physicians, patients, anyone who's interested up to speed on all the changes and events happening in the world of vein health. So moving right along, I've used this word phlebology several times already, but what is it? It's basically the study of venous and lymphatic medicine, which, like I said, wasn't even a subspecialty until just about 15 years ago. So it's a new field of medicine. It's a division of our vascular system focusing on lymphatics and veins. And it's technically a subspecialty of internal medicine, not surgery, which a lot of people just assume this has to be surgery because don't we just do surgery on veins? But that's actually not the case at all anymore. And I'll talk a lot more about modern phlebology as we get deeper into the presentation. But I always like to start off with just a quick slide about epidemiology, or who gets vein problems. And I love this picture because, quite frankly, everybody gets vein problems. It doesn't discriminate. There's, a lot of research on trends in terms of who and when and where and why, but quite frankly, pretty much anyone can have vein problems. We like to think of it as 3 big risk factors. Genetics, so if you have a first-degree relative, meaning a mother or father, who has a vein issue, chances are you're going to have that same predisposition. But we haven't been able to isolate a gene alone. And oftentimes it's not just your genetic predisposition, it's what happens in life with that, meaning your environmental risk factors. So we know, just by living in the United States, your risk is higher than, say, somebody living in Central America. We don't know why, we just know that's the way it is. The countries we label as industrialized, those countries, Northern European countries, US, Canada, all have a much higher incidence of venous disease, which in itself is kind of interesting, but we think it has everything to do with standing for long periods, not taking breaks, no siestas in the US, right? Working on hard floors and working really long shifts. Not to mention a lot of our day-to-day occupations involve standing for really long periods. Then the last bullet point up there, hormonal influences. There's really 3 times in a woman's life when she's undergoing big hormonal influences that are truly the perfect setup to having a venous issue. And for many young women, it starts with their first menses. The whole year after that first period, their bodies are going through all kinds of regulations and regulatory setups to make that cycle come once a month. And during that time, you get pretty big surges of progesterone, which is a great dilator, and it dilates veins too. And sure enough, as veins dilate or get bigger, they can start to fail. The second time, many people know pregnancy is common to bring this on. And historically, we thought it was the third trimester when you'd have a big physiologic barrier that would stop the blood or impede the blood flow back up to the heart. But the reality is, it's the first trimester when, again, we get those big hormonal surges. And then our last high-risk period, as we go through that final change involving menses, menopause, which is coupled with age. So usually when I start talking hormones, people say, well, what about the guys? Can't they get this? And I love that we have our token male in the audience. But yes, men can get venous disease as well. In fact, 40 to 45% of men will have a vein problem, yet curiously, much lower incidence of actually presenting with the visible varicosities or the vein problems we tend to think of more commonly in women. There's a lot of theories on why those numbers reflect that, but for some, they just believe that men will see a vein, see a little spider vein, and think nothing of it until it progresses into a big venous stasis ulcer, when they'll say, oh yeah, I better take care of that. Whereas women might be more self-conscious about their legs, and at first sign of a little spider vein, come in and at least get acknowledged as having an issue. So back to aging. Men generally present later in life, women oftentimes earlier, but the bottom line is, although veins tend to come on later in life, it doesn't mean they are a normal part of aging. And I love this last bullet, that there are solutions for people with this kind of symptom. And I actually, in my notes here, wrote a quote straight from this magazine, which was taken when we interviewed one of my mentors from years and years ago, who has become a geriatrician in his practicing of medicine. And he said, the acceptance of decreased functionality is a detriment to healthy and successful aging. And I just love that quote, because so many people, especially with venous disease, will say, oh yes, my legs ache, yes, they swell, but isn't that normal with age? And the bottom line right there is, no, it's not normal, and it's treatable. So this is one of the big reasons why vein care is important. So with that, what are the symptoms of venous disease? I just mentioned swelling and aching. Pretty much anything bothersome in your legs can be a symptom of venous disease. The more common things are a heaviness that comes on later in the day after you've been standing for long periods, waking up and feeling pretty good, but a slow, steady ache or even a throb that by the late afternoon makes you want to just sit down and elevate your feet. Although there's 101 other symptoms that can often be thought of, as something part of another process. So much so that a lot of times people who have classic symptoms of venous disease, unless they have the big visible veins, never even think that, wow, this could be a vein problem. So the signs over on the right, the ulcers, the skin changes, the woody brown appearance, oftentimes by that point, we say, oh yes, it could be your veins. But the more subtle signs, the spider veins, the aching, the heaviness, a lot of times those are missed. So when you do acknowledge you have a vein problem and you do go to get help, how are vein treatments today in the world of modern phlebology different from what we used to do to people, which most people have heard of as these horrible barbaric treatments that involved stripping veins and all kinds of bad things that weren't even really successful. So in this picture, I have this model cartoon showing blood going towards the heart. In a healthy, normal vein, that's the way it should flow. Remember, your heart pumps blood down to your extremities through arteries. The vein's job is to get it back up. The way the veins do that, because leg veins especially are almost always working against gravity, they have these little valves that open and close. When you squeeze a vein, when you tighten your muscles when you're walking, the little valves open. and the blood can move from one chamber up to the next chamber. Then when you relax, the little valves shut and almost create a floor, so the blood can't go backwards towards your feet. Almost always, when you have a vein problem, it starts where you have normal, healthy flow going towards your heart at a junction, because veins are notorious for dividing and splitting. And at that junction, the little valve will get stuck in the open position. And when that happens, all the blood starts to go in the wrong direction, and it blows out all the valves and all the downstream branches. So with that, if we're going to be successful in treating venous disease, we have to focus right where that yellow line is, right where health meets disease. If we take a shortcut, or if we try to treat downstream because it's just too hard to get up to that spot, what'll happen is we'll stop the flow here, but we'll shift this backflow that's divided into two paths, 100% on the leftover pathway, and sure enough, within 5 years, 80% of people will have the same or worse disease. So we try not to treat any place but the source of the problem. We know this from years and years of doing strippings. When we would do strippings, we generally speaking didn't like to go right to the healthy point, because if we pulled the vein a little bit, we could damage the valve in the healthy segment. So we usually started right where we could see the veins coming through the skin, and it just didn't work real well. So how do we find that spot? Generally speaking, the best way is with ultrasound. Ultrasound is a great diagnostic tool because there's no bioeffect that we know of. It's non-invasive in that we're just putting a little gel on your skin and running a camera up and down your leg. When we do that, you can see the color bar on the right upper corner of the screen. We can tell by color if the blood's going towards the camera or away from the camera. We can also put another function on our machine where we can actually see a little graph of the flow of blood. But with that, we can look right where this black line is a vein, and that black line towards the top where the red is, that's a vein. And we can see right where they come together, and we can interrogate these junctions and see, is this where health comes together with disease? And if not, we can move down and we can fine-tune and actually pinpoint exactly where the highest, most important broken valve is. With that, ultrasound's a little subjective. It takes a really good technician, someone who's very patient, someone who's willing to put you through the process, meaning you have to be standing. If you don't stand, the little valves don't engage, so they just look like they're open all the time. So you can get false negatives and false positives. So you have to not just be standing or tilted on a bed, but you actually have to engage your muscles of the legs to put a little tone on those veins to see if the blood's actually going to stop or continue to go. So just position alone, if you're really nervous and you're really tight, you might get a false positive or a false negative. So being comfortable, having a technician who's willing to take the time and hunt down all the different connections, and having the right credentials, again, really important. There's 2 certifications for ultrasounds who treat or can diagnose venous disease, and those are a registered vascular tech or registered phlebology sonographer. And that's really important just in terms of having the right training to take the right pictures. So once you find the spot where the good guy meets the bad guy, what can we do? Many people think no matter what we do, it's going to be painful or unpleasant, and I'm happy to say that that is no longer the case. In fact, the most common treatment option that we offer is usually an endovenous thermal treatment. In this picture it says laser, but that can be radio frequency waves or it can be laser energy, and it's all done from the inside out. And the nice thing about that is you don't have sensation or innervation of the inside of your veins. So usually what we can do is place a little IV or a little plastic tube into the problematic vein, and then we can slide one of these fancy little fibers or fiber optics right up to the spot where the good guy meets the bad guy, and we can follow that with ultrasound so we will know exactly where that point is. We can add a little numbing medicine to the outside of the vein, then we turn on whatever energy source we're going to use, and it literally just welds the vein shut from the top down. And what that does is it forces the blood to stay in the veins that are working. So it's kind of like sealing off the leaky pathways to force the blood to stay in the healthy channel. So we have endovenous thermal ablation, which, like I said, is probably one of the most common vein treatments available today. It's truly become the gold standard in terms of replacing the classic stripping procedures. And in the world of vein care, stripping's had a 20% success rate at 5 years. The endovenous options have a range, maybe the radio frequency might be down in the 90th percentile, but some of the fancy higher frequency or longer wavelength lasers have well-documented success at up around 98% at 5 years. So that's pretty different and pretty promising. Oftentimes, what those success rates speak to is the idea that we get the big spot closed, which is great, but in the world of veins, nothing is as easy or as straightforward as you might like to think. And sometimes there could be smaller veins contributing or holding these bigger veins open. And for that, we generally will switch to a smaller, less invasive procedure where we might put a little medicine called a sclerosing agent directly into the problematic vein and have the vein seal itself shut. We have lots of different ways to do this, where we can use a little light through the skin, we can use ultrasound guidance, and we have lots of different formulations for options in terms of how to get these veins to close. The important thing, though, is we get all of the backflow gone, so it doesn't act more or less like the Grand Canyon, where you've got a little tiny leak that over time will erode away into a much bigger problem. So a lot of times with the endothermal ablative treatments, we'll use adjunctive treatments like sclerotherapy. But again, small little needle stick directly into the vein, and that's all you feel. There are newer treatments as well. In fact, these, we call them our newer treatments. Varithina's been around for, well, in clinical trials for more than 20 years, so they're not exactly new. But Varithina is a formulation of sclerotherapy. We call it a chemical ablation, where it's a medicine, like a sclerosing agent, it is a sclerosing agent, mixed with a gas to just make it spread out more smoothly, more evenly. But with that, I was jumping ahead to conservative management or compression. I try to always at least say one thing about compression when I do any vein talks anywhere ever, because, like I said, the only treatment that doesn't require at least some time in compression stockings is the cyanoacrylate, or the super glue in the veins. Everything else we use to treat veins requires wearing compression for at least a short period afterward. So with that, if you are considering vein treatment, I strongly urge you to get well informed about compression. Compression has changed a lot in the last, really, 10 years. They're not the thick, ugly taupe granny pantyhose that we all think of, or the thick white stockings that leave the little crisscrosses on your leg. They can look like normal stockings, and they should. And more importantly, they should be comfortable. Compression has always been sized in a way where circumferential measurements are taken and then you're plotted onto a graph and stuck into literally a little box and said, okay, this is your size, here you go, have a good day. The problem is, of course, you can have the same circumferences and maybe be 4 feet or 6 feet, but you won't wear the same pair of stockings. So currently, I think people are more in touch with that than ever, and people who are certified fitters really go the distance to spend time and say, hey, you've got a long knee to ankle ratio. You'll do well in this brand. You won't do well in this brand. Maybe try this one too. And they'll work with you to get into something that can be comfortable. If they fit well, they're surprisingly comfortable. If they don't fit well, they are still quite miserable. So getting a good pair of stockings that's comfortable is critical to any recovery from a vein intervention. With that, I'm always, I can't say surprised, but pleased when someone comes in and they're very gung-ho for an intervention, and I tell them they need to get compression so for aftercare, and they come in and they say, wow, I love my stockings. If I wear them, 75% of the year, do I still need to do this procedure? And I use 75% because I don't think anybody really tolerates these stockings in the summer months, especially when you live in Maine and it's such a short little window. But with that, I'll say, sure, if you want to control this conservatively, if you're willing to wear the stockings, as long as you wear them, you're going to control your symptoms and stop the progression. And half the time, that's just enough to keep people's legs healthy enough to not progress to the end stages of venous disease. So with that, my last few comments on that progression. Even if it's just a little spider vein that you see, even if there isn't a spider vein, but you have some of those symptoms from those earlier slides, venous disease is a continuum. It starts small and it keeps getting worse. And unless you do something as small as getting a pair of compression socks, it's going to keep progressing through time. And eventually you'll start to see the end stages of the disease, which are things no one should suffer with in the year 2019. We're better than that. We have great options and we can help. So with that, any questions about veins, vein health, or the kind of things I do?
You had a picture earlier on where it was open. Oh, sure. There was a picture earlier on where the vein was open. No, next one. No, not next one. Further on. Where you brought it closed with yeah. You went from the left to the vein. Where does the blood go that's there? Does it cool and just sit there and it's fine to be?
So this is the spot that would get closed.
Okay.
So if we pinch that shut, right where that first arrow starts coming down, if we closed that, we'd force the blood to stay in the veins that are already working. And that's the whole principle of how we treat veins today. And it's very counterintuitive. Most people struggle with the idea of sealing a vein shut to improve circulation, but oftentimes we'll have a healthy deep vein, or a vein that lives underneath our muscles. The entire deep system of veins carries about 85% of the venous return. And then we'll have a superficial vein, or a vein that lives right below the skin surface, which even when it was healthy wasn't really contributing very much at all. But it will allow that deep vein, that deep blood, to start getting stuck down at your feet. So by shutting it, we just let the healthy veins do their work. Does that make sense? Good question.
So if you don't, again, when I think about it, how do you know how many veins to cut off? How do you cut off too many?
That's a great question, and a good concern. And the concern is just, can you treat too many veins, or how do you know when enough is enough? And I think in the world of vein health, we're always looking for help. We're looking for the veins that are going up, because from the day this one started having backflow, it doesn't contribute at all. So by closing it, we're not taking anything away from your health. We're actually just helping the one that's already working extra hard get its work done. And also in the world of veins, like I was saying, if your deep veins carry 85% of your venous return, and we're just treating superficial veins for the sake of this talk, that's all the superficial veins combined contributing a very, very small percent, even when they're all healthy. And generally speaking, what we do now is we close a vein at the source, and then your immune system has to process all the downstream branches. So if there's any chance there's a little channel of blood still moving in the right direction, your body will know that, and it will actually preserve that little segment of vein. It'll absorb above, it'll absorb below, but it will preserve anywhere where there's health. So it's a great question.
Is it true that it's also in the United States?
So we don't actually have good research on that.
I always heard that,
But
no.
with in the world of veins are so soft that even the slightest amount of pressure, certainly the pressure from a leg cross, is enough to collapse the vein. However, collapsing the vein isn't necessarily a detriment to its health. It's when you cross and you hold for a prolonged period. So let's say you cross your legs, you get on an airplane, you cross your legs, the person brings their seat down and you're stuck, you can't get uncrossed. Hours go by and your feet are asleep and you really want to uncross but you just can't. That's when damage starts to happen. But in the world of just crossing for a few minutes, crossing your ankle, it probably isn't the best, but I don't think it's as detrimental as we used to think it was. Do you want to do an add-on to that first question?
So what, so you cut it off, I'm just curious.
Sure.
Cut off, and it's like, or cut off.
That's exactly what happens. The first thing we do in any vein treatment, once everything's all set up, is we tilt our tables so your head's lower than your feet. So we use gravity to get all the blood out of that vein. And believe it or not, veins are so gravity dependent that makes a world of difference. So once we have you tilted, we do our treatment, we ideally seal those vein walls shut right on themselves. Over the course of literally about a year for some people, your body's immune system comes, processes all of the vein parts, and it just disappears. So they're reabsorbed and the building blocks are used for other things and your body just takes care of it. Yes?
So I'm 78 years old. So do the walls of the patients get very brittle or very thin? I bruise a lot, so I think is that a vein letting it run out?
Mm-hmm.
What do you do?
So, yes, yes, and yes. As we age, we make less collagen, and that's just a given across the board. And we see it in our skin integrity, and we see it in every part of our body that involves collagen. And vein walls are predominantly made of collagen. So our veins change. They can become more brittle. In the world of bruising, if you're bruising more in your legs, it could easily be because you've got some reflux in your legs. Bruising is one of those things that I tell everybody, don't take that lightly. That can be a sign of a lot of different things. It can be a sign you don't have enough platelets. It can be a sign of literally 101 things that can sometimes be diagnosed with something as easy as a blood test with your primary care doctor. Yes, many medications. Even the aspirin. We tell everybody over 50 these days to take an aspirin. Aspirins are platelet inhibitors and they can help cause bruising. With that, just because you're having increased bruising doesn't mean it's a vein problem and certainly doesn't mean there's a serious problem, but a bruise is basically a little bit of a bleed underneath your skin, and they're almost always venous bleeds because if they were arterial bleeds, they'd become something called a hematoma, which is a really, really bad bruise because arteries bleed more than veins. But with that, if you are concerned, I'm trying to remember, you said the vein walls, the bruising easily, and there is a third part to what you were saying.
Where the veins are thin.
So,
The bruising is like it's
mhm.
on my legs, and I thought maybe it's not rough, and it wasn't.
So if you're feeling like your veins are changing and you're bruising more readily, many things you can do to help with just conservative management of a vein problem. The three big ones: exercising, rhythmic calf contractions of your muscles in your legs will help force the healthy veins to carry the blood upwards. So the more you walk, the more you're going to offload those veins in your legs. The second thing is elevation. And I don't mean sitting all day with your feet up higher than your heart, but short intervals, maybe 3 minutes with your feet higher than your heart, will give your legs a break. If you could do that 3 or 4 times a day, you're basically offloading all the pressures that are building down in your legs. The ideal position is with your head, neck, and torso on the cushions of your couch and your foot up on the armrest. So just a really ever so slight angle, but just getting them higher, your feet higher than your heart. And that'll get that backflow going. And then the third thing, those ever-loved compression socks. They really do make a difference, and they really are protective.
I only do that when I fly.
Mm-hmm. Flying is a great time because flying is another high-risk period. Sure. Other questions? Jen?
Can you just explain why it's doesn't necessarily have to be in an airplane climb, because I know the summer's coming up for a lot of people travel, and you haven't talked much about the deep vein, so I was wondering if you could touch on that.
Sure. It's a good thing to bring up. Protecting your legs in travel. There's a lot out there. But remember, we've been talking about how rhythmic calf contractions helps move blood upward. Whenever we travel, whether we're sitting in an airplane or a car, or just stuck in any type of vehicle for a long period, meaning more than 60 minutes, we tend to not get those rhythmic calf contractions, so blood doesn't have the impetus to move towards our heart. If you add in a little venous disease there, it can really start to pull a lot in your feet. Flying on an airplane, we have pressure changes and we have hydration status to contend with. In cars, we don't necessarily have hydration status to contend with, but when people have a 5-hour drive, they say, oh no, I don't want any water, I don't want anything to drink because I don't want to have to stop to pee. Stopping to pee is a great tool for vein health. Load up on those fluids because that's going to expand your volume in your veins, and which is going to help keep them healthy, and it's going to get you out of your car, get a few rhythmic calf contractions every hour or so, and protect your legs. Clots or problems in your deep veins, deep vein thromboses, can be really problematic. Sometimes they don't even have symptoms. Sometimes the only symptom you get is when you die, and that's not okay. Many people don't realize it, but superficial venous disease is an independent risk factor for deep vein thrombosis. In fact, we think by closing some of the junctions where deep veins connect with superficial veins, we can decrease your lifelong risk of getting a clot by up to about 20%, which is pretty substantial. The other big risk factors for clots, deep vein thromboses, the 3 big ones are if you're stuck in a still position. We call it just being static or stasis. If you have an underlying clotting problem, some of these problems are things you're born with. Factor V Leiden is a very common one. Some of these things are things you acquire, like pregnancy is an acquired hypercoagulable state. Other things, cancers, are acquired hypercoagulable states, and there's a whole list of things that can make your blood just a little too sticky. The third big risk factor is if you have any trauma to a vein wall. So the classic ones we think of are surgeries. Doctors cut right through vein walls all the time. But the ones we don't think about are, we got out of the car and we banged our elbow good, or we're in the airport and that suitcase slams against our leg and we get a big bruise. A bruise is a sign of vein wall injury. So when that happens, our bodies release all kinds of factors to help that bleeding stop, and sometimes they can overshoot the mark. And when they do, they just make our blood more sticky, and that can lead to a clot. So with the world of clots, any cramps that you can't explain, any sudden onset of swelling in just one leg, anything that's even remotely suspicious for a change that doesn't make sense in your leg, it's worth a call to your primary care doctor and just say, hey, this is what's going on. I'm worried about a clot. An ultrasound will tell you if one's there or not and can save your life. It's an easy, non-invasive test. It's silly not to get one. And again, most clots start off non-occlusive, meaning they're a little cluster over in a corner. But because in a deep vein so much blood is going past them, they snowball. They build as the blood passes by. A little more sticks on, a little more sticks on, a little more sticks on. And then all of a sudden that clot is so big it takes up the entire pathway for the entire channel, and then pressure starts to build behind it. And when that happens, that's when it can break free, or thrombose. That's the fancy word for when it embolizes. Sorry, that's the fancy word for when it lets go and travels. And it can go into your lungs and be a pulmonary embolism, or it can go up to your brain and be a stroke. And again, both of which can have no symptoms at all, can have mild symptoms, or can be fatal. So we don't like to mess around with deep vein thromboses. And they're much more common than most people think. Other thoughts or questions on the deep vein thrombosis? I don't like to scare people, but there's some amazing research out there think last year in Maine we lost more than 2,000 people to clots that embolized. In the United States, I don't want to misquote this, but it's more deaths associated with deep vein thrombosis than prostate cancer, breast cancer, AIDS, and traffic accidents combined. That's a lot of people. And it's preventable. It's all preventable. So don't ignore those changes in your legs. It's kind of a dark warning, huh? I didn't mean it to sound so scary. Mm-hmm. Mm-hmm. Yeah, so, you know, those three things I just said, being still, having a hypercoagulable state, and having vascular injury. If you put somebody who has cancer in the hospital for a tumor resection and we get the trifecta, and they're hypercoagulable, they're stuck in bed, and we just damaged all their vessels. Or a pregnant woman who has just delivered via C-section. She's hypercoagulable, she's just had surgery, and she doesn't feel like getting out of bed right away. Why don't these people get clots? And this is really good. When you're in the hospital, doctors know about them, and they try to protect you. And they oftentimes will use something called a TED hoe, which is very different than a modern graduated compression sock. TED is an acronym for thromboembolic deterrent. TED hose are generally the same squeeze from your ankle all the way up, whereas these compression stockings I was talking about, they're usually a graduated squeeze. Somewhere we oftentimes will prescribe 20 to 30 millimeter of mercury, where it's 30 millimeters of mercury is squeeze at your ankle, 25 in your mid-calf, 20 just below your knee, 15 above your knee, 10 in your mid-thigh, 5 in your high thigh. So it's like a funnel pushing the blood back up. And those numbers are important because that's the pressure in your veins when you stand up. Thromboembolic deterrents, or TED hose, are 8 to 15 millimeters of mercury universally. So they don't really do much when you stand up because your pressures are greater than that, but when you're stuck in a hospital bed, they shunt the blood out of your superficial veins into your deep veins, so all of the volume goes to your deep veins, which actually encourages movement back up to your heart. Also, when you're in the hospital, a lot of times they'll use these fancy pumps where they have different squeezes on your legs, and that simulates calf muscle pumping and helps push the blood out of your legs up to your heart. Does that answer your question? How's your grandfather-in-law doing? Okay, we'll talk later. Mm-hmm. Yeah. Other questions? Other concerns about veins? Other big thoughts about vein health? Yes, not high heels. Believe it or not, wardrobe can be a big factor in venous disease. Not uncommon at all for jeans to be so tight at critical spots where they bunch up behind your knees and behind your groin area when you sit down, that they can actually compress a vein. The other thing is with shoes, with super high heels, you don't get the full range of motion at your ankle. So when you take a step, if you're up on your toes, you're not squeezing your calf and relaxing it. You kind of have it tight all the time, which is why we like high heels, because our calves look so strong. But without getting that rhythmic calf contraction, we lose the big push to get the blood back up. I tell people all the time, it's okay to wear your high heels on a fancy occasion, but when you start wearing them every day, you actually shorten that muscle and you decrease that calf squeeze, and that's detrimental to vein health. So special occasions, okay, but not every day. That's a great question that I forgot to mention anything about wardrobe.
Now that I think about it. I'll ask the stupid question about the undervein.
Yeah.
Clearly that can be an indication. But so what is there anything you can do cosmetically if you're thinking about those things?
Not always just vanity behind the spider veins. A lot of times the spider vein is just the tip of the iceberg. Remember, veins branch and split and split and split. Sometimes we'll look at a spider vein and we'll see right where the healthy blood flow starts leaking into the not so healthy vein. And it's right below the skin, and it's a fraction of a millimeter, and it's a super easy treatment. And yes, we call that cosmetic, although I hate that word. Sometimes, and I see this regularly in men, they'll have like one small spider vein, maybe a little swelling at their ankles, or maybe a little something else, maybe not at all. But we'll look with the ultrasound, and that little spider vein will be attached to a bigger reticular vein, which is attached to a bigger varicosity that's just not visible through the skin yet, that goes all the way back down to the deep system. And that goes back to, we don't want to just treat what we see. We always want to look and make sure we're at the source and take it from there. But generally speaking, spider veins go away really easily. And if it's from a deeper source in your leg, we take care of the source and then we just wait and watch. Sometimes it's a whole year from treatment, 6 months to a year before the spiders go away. And we don't do anything else. We just wait and watch, and your immune system takes care of them. Sometimes we look and we say, this is one not to worry about. But if you want it to go away, I can do a little of that sclerotherapy right to that vein, and poof, it goes away kind of magically. Yes?
So at my age, I have plenty of spider.
So maybe it's worth getting checked out. and at your age, I was going to say at your, it's all up to you. I always say sooner is better than later. And even if you just get checked out, at least you know your level of risk and you can respond accordingly. And by coming in, let's say we say, these are all the little ones, you don't have anything to worry about. You do have early stages of venous disease. You already told me your age, and it's not unreasonable to think that you're going to be around for a while and you're going to need those legs. So we can talk about how to optimize their health and how to keep you on track and how to keep this from progressing. Exercise. Walking is a mainstay. And I have to say, I see people regularly in their 90s. And my 90-year-old patients oftentimes are more healthy than my 50-year-old patients. So don't let that number be a deterrent. And certainly don't accept decreased function as normal, because that truly is the detriment to healthy and successful aging. Yes?
Do you know, are most of the procedures covered by insurance? Because I think years ago they weren't.
You're spot on. Most insurance companies base their decision on the same three things I look at when I'm trying to choose what treatment's right for a person. And that's where it is anatomically, where does health meet disease anatomically, how big is that vein that's actually got the backflow in it, and how much pressure is it under. So a little looking at flow dynamics. Based on those three things, if you meet your policy's criteria, of course it'll be covered. And in the world of Maine care, I would say probably about 95% of our treatments are covered. Every now and then we'll get into sticky situations where it's usually with the tiniest of the spider veins, where the insurance company will just say, nope, that's just too small. And the nice thing with that is we've been able to, by following Medicare standards, price accordingly. So if it is something really small, generally speaking, it's not very expensive. But some of the bigger treatments do get quite pricey because of the disposable costs. So it's good that insurances are on board. Other questions? You guys came in late. Do you feel like we're talking about anything from the beginning that you might have missed that you'd like more information on?
The mechanical part of it in the beginning was
Yeah. So we talked a lot about the way veins move blood from your feet up to your heart has everything to do with little valves. And it's a lot like check valves in plumbing, where when you put pressure on your leg by contracting your muscles, like say when you walk, you squeeze the veins, the little valves open, blood moves from one section up to the next section, and then a little valve will shut right behind there and act as a floor. So the blood really moves up our legs segmentally against gravity. And when we have a problem with one of those little doors not shutting all the way, or more likely getting stuck in the open position, that's when vein problems start. And that's almost always at a junction where a healthy vein comes in contact with a not so healthy vein. That's why we were talking about focusing treatments, right where health meets disease.
I have had exposure to varicose.
What was that?
I had treatment with varicose for that.
Mm-hmm.
I think it would be a big improvement for
So we talked about that a little bit too. Sometimes when we do one treatment, we need to more or less finish the job. And that's why, like at our office, we see you, say we did a treatment. We would see you back immediately post-op, 2 months, 6 months, and a whole year out. Because changes happen for a whole year after an intervention. And sometimes we might get the primary source, but there can be secondary, smaller leaks that you can't even see in the beginning. So you sort of have to follow up. And I know a lot of the doctors in our area who are treating veins don't necessarily do all the follow-up. So you're welcome to come over to our office and we'll pick up wherever they left off.
I did a bunch of treatment in a different place. I was so clear.
Oh.
I walk in and there's wrong doctor.
Oh no.
It's helpful to show the slide before this one, which you really want.
Oh, this one, yes.
More effective.
This, thank you, Jen. This is where you want to treat, way up at the source. And sometimes, especially with doctors who might not be quite as skilled in finding this problem, if they treat downstream at where, like I was showing with the slide after this, if they treat here instead of getting all the way where health meets disease, nothing's going to change because there's still going to be backflow.
Yeah, the treatment's good.
Yeah. And then the caveat to that is, if you weren't standing up during the diagnostic ultrasound part, the valves wouldn't have been engaged. So so that's a problem. Yeah. Definitely need to be standing. We need to get those valves to close so we can see which ones are stuck open and which ones are moving properly. So you got to go back and say, I want you to scan me while I'm standing and see what's left over here. Or just come to our office and we'll take care of you. But it's true. Sometimes.
I actually did see you once number yesterday.
Oh, really?
You did an ultrasound.
What's that?
You did an ultrasound.
Okay.
And at the time you mentioned that you might be lame. They crossed from one to the other.
Uh-huh.
And might have been more. That institute had
Uh-huh. Wow. So yeah, that was before I opened my own office. So yeah, I'm in South Portland now. Come back. We'll get you on track. In fact, all of the paperwork over here has our contact information down at the bottom. So please help yourself. And if you have any problems or any worries, don't hesitate to call and schedule an appointment. Or at least hopefully now you're armed with enough education that you can have good conversations with your primary care doctors or other providers about your vein health. Okay?
When you're doing the treatment, can you treat like fine vein and bulging vein at the same time?
Well, usually by treating the bigger of the problems, everything else just goes away. That's always the goal, at least. And that's why it's so important to get that right spot. And that, what's that? The recoup time, small office procedures. But yeah, generally speaking, the recuperation time, pretty limited. Stockings at worst case scenario, maybe 2 weeks. And I tell all of my patients for the first 2 weeks, I want you to walk 30 minutes a day and usually just avoid heavy lifting and hot tubbing for your first 5 days. But other than that, you can go right back to your regular life. And that's kind of a universal for most procedures. Sometimes it'll be a shorter stay in compression, maybe a shorter time walking, but that's the worst case scenario.
Question, if you're working in office, sitting a lot of the time, obviously, but are there things, and like you said, elevating your feet?
Yeah, can't always do that at offices though. Bosses come by and say, what's this? Tapping your toes, tapping your heels, watching the clock. every hour, get up and take a lap to the water cooler, go to the bathroom, move. And if you can't move out of your seat, tap those toes, and when you get done tapping the toes, tap your heels. Rhythmic calf contractions, even when you're sitting, are really, really helpful. Some people like those little things under their desk where their feet can go up and down. But really, just being mindful and moving. Nice. Yeah, I feel like it's nice on the planes. They have those little bars you can put your feet and kind of just pivot on them. So, yeah. That's a great question. Sit-stand stations. So we actually don't have a lot of research in the world of veins, but what I like about them is they don't lock you into a position long-term. If you get tired of standing, you sit. If you're tired of sitting, you stand. And I think just getting in tune with listening to your body and what your body wants is so important in terms of keeping those legs healthy. And this goes back to the idea of, why do they have such a low incidence of venous disease in places like Spain or Central America, where the climate's so much warmer? Heat dilates veins. They should have vein problems. But instead, they take siestas. So they don't do these long 8, 9, 10, 12-hour days where people are on their feet and not able to listen to their bodies, not able to sit down when they're tired, or not able to stand up when they're done sitting. So I think the sit-stands are probably going to prove to be much, much, much more helpful than we even think. But having the option. I know. But moving is key. The other thing too is I think when people stand, they tend to move. They shift their weight. And people who sit, the ideal chairs, have you guys seen those big exercise balls? You can sit on those at work, and then you're forced to just keep your balance, and you move just enough to contract some muscles, and if your office will allow it, they're a great thing. But you can't get the holders. Some people put the holder on it. Then you're just sitting on a ball. Now you gotta keep the balance. Keep moving. Do you remember which one the sit-stand station one was in?
In the standing one, which is
that we don't have. But yeah, we can grab that. The other thing is all of these magazines, and there's a ton more of them, are all on our website. If you go to veinhealthcarecenter.com, there's a section that you can click on Vein Health News. And you can go to the archives, and there's tons of different magazines, and there is one devoted strictly to occupations that require you to stand. The title of the cover story is Standing on the Job, and in that the whole issue is devoted to standing. So
I think there needs to talk about sitting too.
yeah, the balance.
Going back to the question of like the recovery period and the length of that, is there any concern as far as how soon you fly after you have a procedure?
So that's a great question. I used to just across the board say, please don't fly for 2 weeks, but I have patients now who fly in from Canada all the time, and really they get on a plane the very next day and there's no problem. We don't have any clinical evidence or any, studies that show flying is dangerous immediately after a vein treatment. I tell everybody who passes through my care that of course you need to stay hydrated, you need to walk in, you need to wear your stockings, and I've never seen a problem, so no restrictions. I think selfishly, I like to keep my patients close for that immediate post-op period just so I can be there. That'd be absolutely fine. Yeah.
Interesting from Canada they come in.
Oh yeah.
My sister lives in Vancouver, and she has big things. There you go.
I can definitely give you some people out west, or if she wants to come east.
She's always coming.
That's great. All right. Any other questions? All right. You guys have been a great audience. Thank you so much. And Coastal Pharmacy, thank you for having me. And yeah.